Hello, welcome to our presentation on applications of biomimetic ligament regeneration for prevention and treatment of post-hysterectomy pelvic organ prolapse. Warning, this presentation contains sensitive content and graphic images. Pelvic organ prolapse is when the connective tissue around the exterior of the vaginal walls begins to fail, either through weakening or ripping. And this causes the vaginal walls to sag downwards and possibly out of the patient. This is especially common in hysterectomy patients in which the cervix is commonly removed. As you can see in the leftmost image, the cervix serves as a conflux connecting the supporting ligaments that hold up the vaginal walls to it. And as such, 23% of patients experience POP post-hysterectomy, and this risk only goes up with age. The risk market is $1 billion USD, and over 200,000 patients are treated annually in America. Current treatments involve abdominal and laparoscopic sacrocolpopexy surgeries to insert Y-shaped polypropylene vaginal meshes that support the exterior of the vaginal wall. These meshes do not have a set pore size, weight, or geometry, but the pore size is typically large enough to insert a suture or a needle through it. The mesh exposure to polypropylene, however, often leads to scarification, which creates scars, sometimes bridging between organs. And this is a process known as organ welding and is largely irreversible, and it cannot be fully healed from.
The current competition for our device is the transvaginal and Y-shaped meshes produced by Boston Scientific and Johnson & Johnson. However, these companies have been ordered to stop manufacturing by the FDA due to a 27% complication rate. Common complications include vaginal mesh erosion, erosion of the mesh into other organs, vaginal mesh contraction, pain during sexual intercourse, urinary problems, infections, bleeding, and pelvic organ prolapse that returns. Since these types of devices have been banned by the FDA, surgeons will generally perform a native tissue repair to help support the prolapsed organs using the patient's existing ligaments. However, these procedures can involve the removal of excess tissues and the use of generalized synthetic mesh, which carries the potential of causing more harm and trauma to the patient. Our device addresses these problems by using an electrospun collagen fibril mesh that will be seeded with the patient's own cells to mitigate the risk of adverse inflammatory or wound healing responses.
To avoid these types of negative outcomes, our group proposes using an electrospun cross-linked collagen fibril mesh scaffold as a structural support. This scaffold would be seeded with autologous ligament fibroblasts, and the collagen would have glycosaminoglycans like hyaluronic acid introduced into it as an anti-inflammatory factor. This scaffold can either be a preventative measure or a restorative measure for already occurring POP. The implant itself would be sterilized with gamma radiation, and humidity would be introduced to prevent the loss of higher structure that's associated with dry scaffold sterilization.
So for our implant scaffold, we decided to use the composite collagens type 1 and 3 as our material. Type 1 collagen is found in skin, so is more readily available and is also cheaper than type 3 collagen. It also has higher tensile strength than the type 3 collagen. However, type 3 collagen we use in addition to type 1 because it has glycoprotein receptors on it that bind platelets to it, increasing the wound healing response basically around the implant site. However, both promote cell proliferation, controls cell differentiation, modulate cell shape, and have integrin cell surface receptors that bind cells, giving the implant cell adhesive properties. On the bottom right, we have a small diagram showing the difference in amino acid structures between the two types. And for each implant, an estimated raw material cost is about $600 USD. We source the materials from Taskin, since it has both type 1 and type 3 collagen, albeit type 3 in lower concentrations, and is also readily available on the market. So in past studies, 1 milligram per milliliter concentration of hyaluronic acid mixed into collagen has been shown to give the collagen boosted anti-inflammatory properties. So we do this before we go on to the next step in the process, which is electrospinning. On the top right, you can see an untreated electrospun collagen mesh. So in the middle image here, we have a diagram showing how electrospinning works. So you have either a fixed plate or rolling drum that is grounded electrically. And then you have a charged nozzle, which spews protein or polymers. And this process basically turns the proteins or polymers from just a solution, basically, to a long, continuous, like woven strand. And we use this woven strand of collagen to create an electrospun collagen mesh. In one past study, researchers used one of these meshes and seeded it with muscle cells, and it showed a high degree of biointegration and proliferation after a few days. On the topic of biointegration, however, the higher the porosity of the mesh, so basically the porosity of the fibers themselves or the distance between the fibers, the faster the degradation of the implant. However, also the higher degree of biointegration the implant demonstrates. So you need to find basically a balance between the lifespan, the degradation speed of the implant, and the biointegration of the implant, like how well it biointegrates with cells. So we need to increase the scaffold's lifespan. So to do this, we use DHT cross-linking, which stands for dihydrothermal cross-linking. And this process involves heating the collagen past 90 degrees Celsius under a vacuum. It's non-cytotoxic, decreases inflammation around the implant site, increases cellular attachment, and provides much higher strength. So unfortunately, cross-linking decreases biointegration with cells, but is necessary, especially because of this higher strength. So nonetheless, we have to do it, and also increases the lifespan, so it's very important. Another option is EDC cross-linking, which stands for a chemical I will not try to pronounce, but it basically is a chemical process that greatly increases the strength too, but also increases cost and manufacturing time per implant. So because of that, we will not use it, but in case if in preliminary testing, DHT cross-link meshes are not strong enough or don't last long enough, we will add EDC cross-linking into the mix to hopefully get a stronger implant. So on the right side, just reference, you have on the top a DHT treated collagen mesh, then an EDC treated collagen mesh in the middle, and finally a DHT EDC treated collagen mesh on the bottom.
Our device would be indicated for patients requiring a prophylactic hysterectomy that requires ligament removal, which is a hysterectomy done to prevent endometrial and ovarian cancers. OBGYN clinicians should also consider collagen meshes for patients undergoing postmenopausal or post-pregnancy pelvic organ prolapse, post-hysterectomy POP, POP mesh exposure revision, and post-hysterectomy POP prevention. Keep in mind the use case of our device. We determined that the following engineering criteria would be appropriate. First, our device needs to be biocompatible to prevent the organ welding that current mesh devices can cause. To do so, our device should have a hyaluronic acid concentration of 1 milligram per 1 milliliter. Next, our device should prevent and reverse any slipping of pelvic organs. Therefore, we need this device to promote the growth of ligament fibroblasts within the scaffolding by having a fibroblast density of greater than 9.1 per 1,000 micrometers. Additionally, our device needs to withstand the tensile forces from the vaginal cuff, requiring a stiffness of greater than 0.62 newtons per millimeter. Third, our device must maintain a near lifelong result, so it must maintain the approximate stiffness values for 15 or more years. We'll ensure this specification by performing cyclical testing to give us a more accurate view of the device's tensile strength over time. Finally, this device needs to be simple to implant. To prevent any unnecessary learning curve for physicians, our device will share its general geometry with current Y-shaped mesh designs, including a pore diameter of greater than 1 millimeter for easy suturing. Next, Ellie will detail the various experimentation and validation methods we'll use to test our device, including mechanical, biocompatibility, and cell response testing, along with preclinical models.
Mechanical testing for this implant would be a uniaxial or biaxial tensile test, in which the force would be along and perpendicular to the native loading direction. We would experiment with wet versus dry, in this case meaning encapsulated in hydrogel versus non-encapsulated in hydrogel, and seated versus unseated with the cells. The range that we're looking for the stiffness is roughly 0.62 newtons per millimeter to 6.9 newtons per millimeter. And we would validate this against porcine uterine ligaments, which seem to have the same mechanical properties as the human uterosacral ligament. During these tests, we would also pre-cycle it with tension along the native loading direction with a minimum of 10 cycles ranging from 0.1 to 2 newtons. And this is because the change in modulus, the secant modulus specifically, decreases as the cycling increases. So there, at the beginning, there's a large increase and that sort of tapers off. For our biocompatibility testing, we would first verify the chemical composition using Fourier transform infrared spectroscopy. We would verify that there's the presence of collagen 1, 3, and hyaluronic acid, and then we would quantify the further composition, verifying specifically that the hyaluronic acid is 1 milligram per milliliter. We would also perform cytotoxicity assays, specifically MTS assays and agar overlay assays, looking at the collagen and hyaluronic acid scaffold versus just the collagen without the hyaluronic acid. And during these tests, if cell lysis is less than or equal to 50%, this would be deemed viable for cytotoxicity. Additionally, we would test the distribution and infiltration of the cells into the scaffolds using an MTS assay. The assays would be staggered over 1, 2, 6, and 24 hours, and the optical density would be used to calculate the seeding efficiency. Additionally, there would be a visual inspection digital analysis with DAB stain for nucleus count. We would compare the nucleus count to literature for premenopausal ligaments, and an ideal value would be roughly 9.7 nuclei per 1,000 micrometers squared. We would also test the inflammation or immune response using an ELISA assay. We'd be looking for M1 or M2 cytokines, chemokines, and growth factors. The presence of M1 cytokines would indicate a pro-inflammatory response, while the M2 cytokines, specifically the M2C type, would indicate a more positive wound healing response. These results would be controlled against the immune response for polypropylene mesh by Boston Scientific. As a final step for our experimentation, we would move on to preclinical animal models. Our small rodents, specifically mice and rats, we would be looking at a simple collagen hyaluronic acid disc as a dermal implant. After this is implanted, we would be looking at carcinogenicity, systemic toxicity, and local and systemic immune response in the rats and mice. For our larger animals whose uterosacral ligaments align more with the human uterosacral ligaments, we would be looking at animal implantation of the actual device. After this device is implanted, we would be looking at the local and systemic immune responses, and we would also perform mechanical testing and morphological assays on any explants that we recover. For our mechanical testing of the explants, we would be looking at the pre-creep, elastic, cyclical loading, and creep behavior to validate that with our other data preclinical trials. However, like all medical implants and techniques, this approach is not without its limitations. First of all, the cross-linking involved in getting the collagen to last longer can reduce cell viability. So getting the balance between those two properties will be very important. The literature available for uterosacral ligament mechanical properties and other properties as well is also limited. So any benchmark values that we have will need additional validation. Also, the raw material cost for a collagen scaffold exceeds the raw material costs for polypropylene meshes, which means the final cost of the finished product will likely be more expensive as well. Also, using autologous fibroblasts means that we have to source the cells from the patient's own body, which would also require an additional procedure, which is not ideal for patient quality of life. Finally, the implants are intended for lifetime use, which means that any data that we use from cyclical preloading will be heavily extrapolated, as no matter how many cycles you get, it's hard to extrapolate until 20 plus years from now, which will reduce the accuracy of any predictions that we make.